Welcome to Asthma, Part 2. The following clinical manifestations result from pathophysiologic mechanisms caused by or activated by bronchospasm and excessive bronchial secretions, the major anatomic alterations of the lungs that are associated with an asthma episode: bronchospasm and excessive bronchial secretions. Let's take a look at what some of these are. The physical examination in asthma. Common vital signs seen during the physical examination include an increased respiratory rate, often due to stimulation of the peripheral chemoreceptors or hypoxemia. It's the first sign of hypoxemia, in fact. Decreased lung compliance and increased respiratory rate relationship. Because the lungs are hyperinflated, the patient has to work harder to breathe at that flat portion of the pressure-volume curve. And the last reason they may have an increased respiratory rate is anxiety. You may also see an increased heart rate and increased blood pressure. Use of accessory muscles during inspiration is common, as well as use of accessory muscles during expiration. Expiration may be prolonged. You may see pursed-lip breathing as well, and substernal and intercostal retractions because of the increased work of breathing. Increased anterior-posterior chest diameter or barrel chest is another common thing seen during the cardiopulmonary physical examination at the patient's bedside. Cyanosis, or a bluish tint to the skin, is a late sign of hypoxemia. It happens when 5 milligrams of hemoglobin have been deoxygenated. Cough and sputum production. During an asthma attack, the patient may produce an excessive amount of thick and tenacious secretions. At other times, because of the large number of eosinophils and other white blood cells, sputum may be yellow or green in color, purulent. Pulsus Paradoxus is an interesting phenomena when an asthma attack produces severe alveolar air trapping and hyperventilation. Pulsus Paradoxus is a classic clinical manifestation. Pulsus Paradoxus is defined as systolic blood pressure that is more than 10 millimeters of mercury lower on inspiration than on expiration. This exaggerated waxing and waning of arterial blood pressure can be detected by using a manual blood pressure cuff or, in severe cases, by palpating the strength of the pulse. Pulsus paradoxus during an asthma attack is believed to be caused by the intrapleural pressure swings that occur during inspiration and expiration and is associated with a severe life-threatening condition. Chest assessment findings. A prolonged expiratory phase. In fact, the expiratory phase as compared to the inspiratory phase may be 3 times longer. In other words, it takes them 3 times longer to exhale. There may also be diminished tactile and vocal fremitus, a hyperresonant percussion note, diminished breath sounds, diminished heart tones, wheezing, or crackles. Common pulmonary function test findings in moderate to severe asthma episode include a diminished FVC, a diminished FEV1, FEV1 to FVC ratio may be decreased, FEF 50 and MVV may also be decreased, FEF 200, 1200 may also be diminished, and a diminished peak flow, if they can do a peak flow at all. Blood gas in mild, arterial blood gases in mild to moderate asthma. Reveal acute respiratory alkalosis, usually associated also with hypoxemia. The patient has a high respiratory rate, driving down the CO2 and driving up the pH. The bicarb is normal, but on the low side. The PaO2 and oxygen saturations are also low. In severe asthma or acute ventilatory failure with hypoxemia, the arterial blood gas pH drops. The PaCO2 rises. The bicarb hasn't had a chance to change yet, so it's still normal. And the PaO2 and SaO2 drop. This is an acute respiratory acidosis or acute ventilatory failure, and a sign of extreme distress. Oxygen indices, QS to QT, will be increased. Oxygen difference diminished. Ventilatory different oxygen can be normal, as well as content of arterial to venous oxygen. Abnormal laboratory tests and procedures. Sputum on examination may reveal eosinophilia, Charcot-Leyden crystals, casts of mucus from the small airway or Kirschmann spirals. The IgE level may be elevated in extrinsic asthma. Let's look at some chest x-rays. Again, on chest x-ray, you may see an increased anterior-posterior diameter or barrel chest. The lung fields may look translucent or dark, and you may have depressed or flattened diaphragms from air trapping and a tubular heart. Also very common from air trapping, as the alveoli become enlarged during an asthma attack. The residual volume and functional residual capacity increase. This condition decreases the radiographic density of the lungs, hence the dark lung fields that you see here. Consequently, the chest radiograph shows lung shadows that are translucent or darker than normal in appearance. Because of the increased residual volume, functional residual capacity, and total lung capacity, the diaphragms are depressed and flattened. Again, you can see that here in this chest x-ray of a 2-year-old patient during an acute asthma attack. You can see the stomach bubble just below the diaphragm and how squished the heart looks. So now you know what a patient looks like in an acute asthma attack, but how do we manage this to keep it from happening? Long-term goals for asthma management are symptom control, risk reduction, making sure that controller medications and rescue medications are on hand, and possibly add-on therapies for patients with severe asthma. Let's talk about what some of these are. Controller medications are agents that are used for regular maintenance treatment. They decrease airway inflammation, control symptoms, and reduce future risks for exacerbations and decrease lung functions. Commonly used controller medications are beclomethasone, fluticasone, Qvar, Aerospan, Flovent, Pulmicort, Asthmanex, Elvesco. All of these are common inhaled corticosteroids. Also used for long-term control are short-acting bronchodilators for relief. Short-acting bronchodilator agents are albuterol or Preventol, Venolin, ProAir, Acuneb, generic, metoprolol, generic, and levobuterol, Xopenex, Xopenex HFA, and generic. Some of the add-on therapies include an inhaled corticosteroid and long-acting LABA, long-acting beta-2 agent, or LABA. Fluticasone and salmeterol combined are in Advair. Budesonide and formoterol combined are in Symbicort. Mometasone and formoterol combined are in Dulara. So, we want to diagnose, assess, adjust treatment, and review response. Our diagnosis should include symptom control and risk factors, including pulmonary function testing, inhaler technique and adherence, patient preference, what works for them. We should consider what are the appropriate asthma medications, non-pharmacologic strategies, treat modifiable risk factors, get rid of the cat, if possible, vacuum once a week, pillows that are non-allergenic, a mattress cover, and quit smoking. Symptoms, exacerbations, side effects, patient satisfaction, and lung function. Let's look at Gina's stepwise asthma management approach for adults, adolescents, and children from 6 to 11 years. Step 1. As-needed reliever inhaler. The preferred option is to start the patient on an as-needed short-acting beta-2 agonist or SABA. An example of this would be albuterol. This is highly effective in controlling asthma symptoms quickly. A second controller option is a regular low-dose inhaled corticosteroid, in addition to as-needed SABA, such as albuterol, in patients at risk for exacerbation. In Step 2. So Step 2 is a low-dose controller medication plus an as-needed reliever medication. The preferred option is to place a patient on a regular low-dose inhaled corticosteroid plus an as-needed short-acting beta agonist like albuterol. Inhaled corticosteroids at low doses have been shown to decrease asthma symptoms, improve lung function and quality of life, and reduce the risk for exacerbations and asthma-related hospitalizations and deaths. Step 3. The two preferred options for adults and adolescents are a combination of a low-dose inhaled corticosteroid, ICS, and LABA, or long-acting bronchodilators, as maintenance treatment, plus an as-needed short-acting bronchodilator. Inhaled corticosteroid options include Qvar, Aerospan, Flovent, Pulmicort, Asmanex, or Alvesco. Short-acting bronchodilators for relief include albuterol, metoprolol, generic, and levobuterol. Long-acting bronchodilators, or long-acting beta-2 agents, LABAs, include Ceravent and formoterol. These can come in combination with a inhaled corticosteroid, as in Advair, which is fluticasone and salmeterol, or Symbicort, which is budesonide and formoterol, or Dulara, which is mometasone and formoterol. Many people prefer formoterol as a long-acting bronchodilator because it comes on more quickly and lasts 12 hours. Step 4. The preferred option for adults and adolescents is a medium-high dose of an inhaled corticosteroid and a long-acting bronchodilator, plus an as-needed short-acting bronchodilator. For adult patients with allergic rhinitis and sensitized to house dust mites with exacerbations despite low-dose inhaled corticosteroids, the physician may consider adding tiotropium bromide or a high dose of inhaled corticosteroid or LABA combination. The preferred option for children 6 to 11 years is a referral for expert advice by a pediatric pulmonologist. Level 5. The preferred option for Step 5 is referral to a specialist, a pulmonologist, for investigation and consideration of add-on therapies and treatments. Add-on therapies include tiotropium bromide, a long-acting muscarinic antagonist, suitable for patients 2 years and older, add-on anti-immunoglobulin therapy, such as anti-IgE therapy, interleukin treatment for patients 12 years and older with severe eosinophilic asthma, sputum-guided treatment for patients with persisting symptoms or exacerbations despite high-dose ICS and LABA combo, Treatment may be based on eosinophilia in sputum of greater than 3%. An add-on low-dose corticosteroid burst, less than 7.5 milligrams a day for prednisone, may be helpful for adults with eosinophilia or severe add-on. The last add-on treatment is bronchial thermoplasty. Bronchial thermoplasty involves the use of therapeutic radiofrequency energy applied to the airway walls. The procedure entails insertion of a standard flexible bronchoscope through the patient's nose or mouth and into the lungs. The tip of the small diameter catheter, which is threaded through the bronchoscope, is then introduced out into the bronchus and expanded to contract the walls of the targeted airway, shown by the arrow. A controlled thermal energy is then applied to the bronchial airways, which in turn heats the airway tissues and shrinks the bronchial smooth muscles that cause the airways to constrict during an asthma episode. This treatment has been shown to cause acute epithelial destruction, followed by regeneration of the epithelial, blood vessels, mucosa, and nerves. The bronchial smooth muscles, however, demonstrate no remarkable regeneration and instead are replaced by connective tissue. The full treatment course includes 3 different bronchial thermoplasty procedures: 1 treatment for the left lower lobe, 1 treatment for the right lower lobe, 1 treatment for both right and left upper lobes. Each procedure is performed at least 3 weeks apart. Side effects include coughing, wheezing, and shortness of breath. Bronchial thermoplasty is indicated for patients with severe and persistent asthma who are 18 years old and older and whose asthma is not well controlled with long-acting broncho beta agonists and high-dose inhaled corticosteroids. Patients who have been treated with bronchial thermoplasty have been shown to have a reduction in severe asthma attacks, fewer visits to the emergency department, and a drop in hospitalization. Non-pharmacologic interventions for asthma. In addition to taking medications for asthma, a number of other therapies may be helpful in control of asthma or future exacerbation risks. Some of these include smoking cessation, physical activity, avoidance of occupational exposures, avoidance of medications that make your asthma worse, like aspirin and NSAIDs, a healthy diet, avoidance of indoor allergens, allergen immunotherapy, weight reduction in obese patients, breathing exercises, avoidance of indoor and outdoor pollution, encourage influenza vaccines, bronchial thermoplasty, and encourage strategies to deal with emotional stress, avoidance of certain foods and chemicals. Indications for referral to expert evaluation. Most patients with asthma usually can be controlled in primary care. Some clinics justify the referral for expert advice regarding the diagnosis and/or management of asthma. Some common indications include difficulty confirming the diagnosis of asthma, suspected occupational asthma, persistent uncontrolled asthma or frequent exacerbations, any risk factors for an asthma-related death, evidence of or risk for significant treatment side effects, symptoms suggesting complications or subtypes of asthma. Protocols for when asthma is controlled. When asthma control has been achieved, regular and ongoing monitoring of a patient's symptoms, risk factors, occurrence and exacerbations, and documentation of responses is essential to maintain control and determine which is the lowest step and lowest dose of treatment needed. This minimizes the cost and maximizes the safety of the treatment. It's important to establish the patient's adherence with the medications and any other advice or factors that contribute to poor adherence. It's essential to ensure the patient has a full understanding of all asthma information associated with the patient's condition, and it's essential that the patient have an asthma action plan that's appropriately designed for that. Asthma action plans help to manage asthma exacerbations. An asthma exacerbation is characterized by a progressive increase in symptoms of shortness of breath, wheezing, chest tightness, or progressive decrease in lung function. Exacerbations may occur in patients with pre-existing condition. Severe asthma exacerbations are potentially life-threatening, and their monitoring and treatment require close supervision by trained medical personnel. Special populations. Several comorbidities are often associated with asthma, especially those with difficult-to-treat asthma or severe asthma. Obesity. Asthma is more difficult to control in obese patients. Weight loss in obese patients improves asthma control and lung function. GERD. Significant evidence indicates that gastroesophageal reflux is more common in patients with asthma and obstructive sleep apnea than the general population. Anxiety and depression. Psychiatric disorders, especially depression and anxiety disorders, are common among people with asthma. Food and allergy and anaphylaxis. Although food allergy as a trigger for asthma symptoms is rare, less than 2% of all people with asthma. Patients with confirmed food-induced allergic reaction or anaphylaxis coexisting with asthma are a very strong risk factor for more severe and even fatal reactions. Food-induced anaphylaxis often presents as life-threatening asthma. In these patients, special medications are required. Rhinitis, sinusitis, and nasal polyps are also common in patients with asthma. Pregnancy, occupational asthma, the elderly, and exercise-induced asthma also all require special treatments and may be hard to diagnose. Aspirin-induced respiratory disease is well documented and often starts with nasal congestion and progresses to chronic rhinitis. Asthma and hypersensitivity to asthma develop shortly after. Difficult to treat or severe asthma refer to patients with ongoing factors such as comorbidities, poor adherence, allergen exposure. Treatment-resistant asthma refers to a patient with confirmed diagnosis of asthma but in whom symptoms or exacerbations remain poorly controlled in spite of high-dose inhaled corticosteroids and LABAs. Severe asthma includes patients with refractory asthma and those who have not fully responded to treatment. This is an example of an asthma action plan. As you can see, it's broken into 3 parts: green, yellow, and red. Green, good to go. You're on whatever your regular medication controller medications are. Use as prescribed. No cough or wheezing. You can work and play, and you're able to sleep at night. Yellow is caution. Take your daily medications and possibly call your doctor to add more medications if your symptoms don't get better. You may have a cough, a wheeze, tight chest, or be waking up at night. These are not normal and again, need an adjustment to the daily medications. Red is danger. Stop. Your medicine isn't helping. You're breathing hard and fast. Your nasal flaring is occurring. You can't walk or talk, and your ribs are retracting. You may need to call 911 if albuterol is not working. Asthma management in primary care. This shows a typical asthma management plan in primary care. The patient is assessed. It's determined whether they have mild, moderate, or severe or life-threatening disease. If the disease is mild to moderate, they're started on a short-acting bronchodilator. In adults, they're started on prednisone, and then treatment is controlled with ASABA as needed and reassessed. Follow-up is arranged with a reliever to go home and a controller. They may continue the prednisone for 5 to 7 days and follow up within the week with an action plan on board. Asthma management in acute care is a little different. Initial assessment includes airway, breathing, and circulation, and does the patient have any drowsiness, confusion, or a silent chest? If they do, they may be sent immediately to ICU, intubated, or put on a ventilator. This would be considered severe. If they don't, then they may be triaged by clinical status. Can they talk in full sentences, or are they limited by talking in words? Are they sitting, hunched forward? Are they agitated, or do they seem calm? Are they using their accessory muscles? Depending on whether they fall into mild or moderate or severe categories, short-acting bronchodilators will be started, possibly with ipratropium bromide, controlled with oxygen to keep saturations 93 to 95, and oral corticosteroids may be started. They may get IV magnesium, IV corticosteroids, and even high-dose ICS, depending on the severity. Reassessment is vital to see how they're doing after an hour. If the patient is falling into the moderate category, if they're talking, if you can hear if breath sounds have improved, they may be able to go home. If they haven't, then they may be admitted for further treatment or on a 24-hour hold. Aerosolized medication protocol includes inhaled beta-2 agonist, anticholinergic agents, corticosteroids agents via metered dose inhaler, spacer, dry powdered inhaler, or small volume nebulizer are common in the treatment of asthma. To induce bronchial smooth muscle relaxation, continuous nebulization of albuterol is often used in the management of status asthmaticus or severe asthma to prevent acute ventilatory failure. Reassessment is vital. Oxygen therapy protocol. Oxygen therapy may be required to treat hypoxemia, decrease work of breathing, and decrease the work of the heart. The hypoxemia that develops in asthma is usually caused by ventilation-perfusion mismatch and shunt-like effects. These are associated with bronchospasm and increased airway secretions. Hypoxemia caused by this shunt-like effect can at least partially be corrected by oxygen therapy. Airway clearance therapy. Because of the excessive amount of mucus production and secretion accumulation associated with asthma, a number of bronchial hygiene treatment modalities may be used to enhance bronchial secretion mobilization. These should not be attempted with patients with acute asthma until they can effectively move air and take a deep breath and cough. Mechanical ventilation. Because acute ventilatory failure is often associated with status asthmaticus, continuous mechanical ventilation may be required to maintain an adequate ventilatory status. Status asthmaticus is defined as severe asthma episode that does not respond to conventional pharmacologic therapy. When the patient becomes fatigued and the ventilatory rate diminishes, clinically, the patient demonstrates a progressive decrease in PaO2 and pH and a steady increase in PaCO2. Acute ventilatory failure has happened. Non-invasive ventilatory assistance, positive airway pressure, or bilevel positive airway pressure may be indicated if the patient is awake and talking. However, you must be able to provide frequent or continuous bronchodilator therapy. If ventilation does not improve quickly and hypercarbia is not reversed, intubation and mechanical ventilation will become necessary. Thank you. This has been Asthma Part 2.